What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my neurology playlist. In previous videos, we talked about strokes, whether ischemic stroke or hemorrhagic stroke. We talked about the Cushing triad. We talked about the Glasgow Coma Scale. We talked about neurogenic shock. We talked about dopamine, and we talked about Duchenne muscular dystrophy and Becker's muscular dystrophy. Then we started talking about neurological diseases that can cause muscle weakness. We talked about multiple sclerosis in its own video and Guillain-Barré Syndrome in its own video, but today it's time to compare between the two. Demyelination of the central nervous system versus demyelination of the peripheral nervous system. Autoimmune attack against the oligodendrocytes versus autoimmune attacks against Schwann cells. Upper motor neuron lesion versus lower motor neuron lesion. It's MS versus GBS. Click the like button, click the subscribe button, and let's get started. I have two neuro playlists on this channel. One is called Neuroanatomy, and the other is called Neurology and Neuroscience. In previous videos, we talked about stroke, we talked about shock, we talked about the Cushing triad or the Cushing reflex, anti-seizure medications or anti-epileptics, Duchenne muscular dystrophy, Becker muscular dystrophy. We talked about dopamine and the neural pathways. We talked about Glasgow Coma Scale. We talked about Guillain-Barré and MS. So in this video, we'll talk about multiple sclerosis and compare it with Guillain-Barré syndrome on many aspects. Starting with, where are we in this chart? Well, multiple sclerosis is a problem in the central nervous system, so multiple sclerosis is here. How about Guillain-Barré? Now, Guillain-Barré is in the peripheral nervous system, so it attacks here. It attacks the peripheral nerve and the nerve root. And that's why we say that Guillain-Barré syndrome is a polyradiculoneuropathy. If I have a problem in the brain, it's called encephalopathy. In the meninges, it's meningitis. If I have a problem in the spinal cord, myelopathy. In the nerve root, as it exits the spinal cord, radiculopathy. In the peripheral nerve itself, peripheral neuropathy. In the muscle, it's myopathy. So, multiple sclerosis affects the brain and the spinal cord. This is multiple sclerosis, but Guillain-Barré is radiculopathy and neuropathy, as you see. Multiple sclerosis causes demyelination of the central nervous system. However, Guillain-Barré syndrome is going to affect the nerve roots, radiculopathy, and the peripheral nerve itself, peripheral neuropathy. Put them together, polyradiculoneuropathy. Many nerve roots and many peripheral nerves. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. Normally, what's the name of the cell that myelinates the central nervous system? It's the oligodendrocytes. And what's the name of the cell that myelinates the peripheral nervous system? It's Schwann cell. If you wish to see more videos like this in the future, please drop a brain emoji in the comments. What is the central nervous system? The brain and the spinal cord, and that's it. But what's the peripheral nervous system? It's the cranial nerves and the spinal nerves, except the optic nerve. So multiple sclerosis is going to cause demyelination of the brain. It can lead to demyelination of the spinal cord and of the optic nerve only out of all the nerves. As for Guillain-Barré syndrome, it can take care of the other nerves. So all of the cranial nerves except the optic and all the spinal nerves can be affected. Please don't forget your phrenic nerve because C345 keep the diaphragm alive. Guillain-Barré syndrome can lead to diaphragmatic paralysis and respiratory insufficiency, and that's why we might need a ventilator. Multiple sclerosis affects the oligodendrocytes, but Guillain-Barré syndrome damages the Schwann cells. Motor system has upper motor neuron and lower motor neuron. Upper motor neuron is part of the central nervous system, so multiple sclerosis affects upper motor neuron and causes upper motor neuron lesion. Conversely, Guillain-Barré syndrome affects the peripheral nervous system and causes lower motor neuron lesion. All of this is the upper motor neuron, but this is the lower motor neuron. When multiple sclerosis affects the upper motor neuron and causes upper motor neuron lesion, expect to see hypertonia, hyperreflexia, positive Babinski sign, and spastic paresis. But when Guillain-Barré syndrome causes lower motor neuron lesion, expect the opposite, hypotonia, hyporeflexia, negative Babinski, and flaccid paralysis. How many cranial nerves you have? I have 12. Which one is part of the central nervous system? The optic nerve. So multiple sclerosis can lead to optic neuritis, retrobulbar neuritis, eventually optic atrophy, and blindness. But Guillain-Barré syndrome can take care of the rest. So with Guillain-Barré syndrome, I can suffer from what? Ophthalmoplegia, because I affected cranial nerves 3 and 4 and 6. So I can get double vision. Let's compare between multiple sclerosis and Guillain-Barré when it comes to the definition. Multiple sclerosis is a chronic, but Guillain-Barré is acute. MS is autoimmune demyelination of the CNS, but Guillain-Barré is immune-mediated demyelination of the PNS. With MS, I get upper motor neuron lesion with hypertonia, hyperreflexia, positive Babinski, and spastic paresis. But with GBS, I get lower motor neuron lesion with hypotonia, hyporeflexia, negative Babinski, and flaccid paralysis with some fasciculations. MS has multiple symptoms, hence multiple sclerosis. What does sclerosis mean? Infiltration. Multiple symptoms are the sensory or motor, both sensory and motor, relapsing and remitting. They come and they go over time and space. So in 2000, I had multiple sclerosis in my left foot. Then it went away and then came back in 2002 in my right arm. Then it disappeared and came back in 2005. Now it's in my left eye, etc., etc., etc. Guillain-Barré is polyradiculoneuropathy, multiple pathologies in the nerve root and the peripheral nerves, with predominantly motor symptoms. However, with MS, you have motor symptoms, you have sensory symptoms, and you have autonomic symptoms. But Guillain-Barré, for the most part, is predominantly motor, mainly acute, flaccid, ascending paralysis. Some synonyms. MS is also known as disseminated sclerosis, whereas Guillain-Barré syndrome is also known as acute inflammatory demyelinating polyradiculoneuropathy. In multiple sclerosis, my immune system is attacking the oligodendrocytes, leading to demyelination of the central nervous system, causing motor symptoms and sensory symptoms. The motor symptoms are upper motor neuron lesion. The sensory deficits include tingling, numbness, could be hypoesthesia or hyperesthesia. As for GBS, it's probably infection-induced abnormal immune response attacking my Schwann cells. Who is attacking? Both the B lymphocytes and the T lymphocytes. So it's a humoral response and a cell-mediated response. This will demyelinate my peripheral nervous system, giving me lower motor neuron lesion. Multiple sclerosis demographics and risk factors. Many patients are between 20 and 40 years of age. It's more common in females than males. It's more common in the north than the south. Related to vitamin D deficiency or decreased exposure to sunlight, associated with human leukocytic antigen DRB1 and human leukocytic antigen DQA1 and others, probably associated with Epstein-Barr virus and human herpes virus number 8, the same virus that causes what kind of tumor? If you know the answer to this question, please let me know in the comments. Smoking is a risk factor, and being born in one of the months of the spring for some reason is a risk factor or an association. But remember, correlation is not causation. As for Guillain-Barré syndrome, something happens and then 1 to 4 weeks later, the neurological manifestations begin. That something could be viral infection, could be bacterial infection, especially Campylobacter jejuni, mycoplasma, and even Lyme disease. Surgery can trigger Guillain-Barré syndrome. Inoculations can do it. Lymphoma and lupus may be associated with Guillain-Barré. Guillain-Barré syndrome is an ascending paralysis. Just like transverse myelitis, what does myelo mean? Spinal cord, because it's in the core. Myelo means core. The spinal cord is in the core of the vertebral column, and itis means inflammation. Tick paralysis, also ascending. But descending paralyses include botulinum toxin or botulism, myasthenia gravis, which is the topic of the next video, and diphtheria, the same nasty bacteria that causes pseudomembranous pharyngitis, the only pharyngitis in medicine that has a dirty, necrotic, nasty, shaggy membrane that is adherent and does not want to be removed. If you force remove it, it's going to bleed. Nothing else causes this except diphtheria. Clinical picture of MS first, then clinical picture of Guillain-Barré. Multiple sclerosis clinical picture includes symptoms and signs. Symptoms are the patient's complaints. Signs is what the physician discovers on physical exam. How do I remember this? The word symptoms has a Y, so you, the patient, will tell me what's up. But signs has an I. I, as a doctor, is going to discover something on physical exam. The symptoms of MS include scotoma or visual field defects, decreased visual acuity, subjective decreased color saturation, decreased brightness, dull pain worsened by eye movement, diplopia caused by the internuclear ophthalmoplegia or by paralysis of the abducens nerve, which is the sixth cranial nerve. The patient might say, "Doctor, my limb is like as if it's tightly wrapped. It feels dull." Fatigue, loss of dexterity, tripping and falling, vertigo, gait disturbances, urinary symptoms, constipation. Exposure to heat makes the symptoms of MS worse, whether it's a hot bath or even exercise, and this is called the Otoff phenomenon. Signs of MS include horizontal nystagmus, optic neuritis, later optic atrophy, and then two pupils, Marcus gun pupil and Argyll-Robertson pupil, also known as the prostitute's eye, which accommodates but does not react. In order to diagnose Marcus gun pupil, you need to be able to swing the flashlight quickly. But if you examine each eye separately, you will not discover Marcus gun pupil. Optic atrophy can lead to blindness. Internuclear ophthalmoplegia, usually bilateral, but could be unilateral. Sensations could be decreased or heightened. Hyposthesia or hyperesthesia. Positive Laramide sign. What does that mean? Forward flexion of the neck creates an electric shock sensation down the spine. Foot drop is common. Sexual dysfunction can happen because I told you that MS is a motor problem, eye problem, sensory problem, and autonomic problem. It's upper motor neuron lesion, so we expect hypertonia, hyperreflexia, positive Babinski, and spasticity. Gait disturbances and scanning speech because MS can affect the poor cerebellum. Because I do not know where you studied neuroanatomy, but where I grew up, the cerebellum is still part of the central nervous system. Multiple sclerosis can trash any part of my central nervous system. Remember that the eye is part of the central nervous system, just like the optic nerve. But MS is not peculiar in the CNS. MS might affect the PNS as well. To summarize multiple sclerosis symptoms, we have multiple symptoms, sensory and motor, relapsing and remitting over time and space, with optic neuritis, positive Laramide sign, and Otoff's phenomenon. Next, the clinical picture of Guillain-Barré Syndrome, symptoms and signs. Mostly motor. In one sentence, we have muscle weakness in more than one limb with areflexia, or absent reflexes. We have symmetric weakness, right and left, proximal and distal. The patient might have difficulty climbing upstairs, getting up from a chair. It is ascending paralysis. Back pain is not uncommon. Paresthesia can happen. Yes, it's mostly motor. However, some sensory symptoms can happen. Autonomic symptoms can happen as well. But it's predominantly a motor disease. What is the most heartbreaking thing? Respiratory insufficiency, because remember that the diaphragm is supplied by the phrenic nerve, which is a peripheral nerve, and demyelination of the peripheral nervous system is what happens in Guillain-Barré syndrome. Facial weakness, ophthalmoparesis, or weakness of the eye muscles, because the eye muscles are supplied by cranial nerves 3, 4, and 6, and all of these are peripheral nerves, part of the peripheral nervous system. Papilledema can happen, dysphagia can happen. Multiple sclerosis has many clinical variants, including relapsing remitting multiple sclerosis, primary progressive, secondary progressive, Marburg variant, ballot concentric sclerosis, and shoulder diffuse sclerosis. As for Guillain-Barré syndrome, it has acute inflammatory demyelinating polyradiculopathy, which is the most common one, acute motor axonal neuropathy, acute motor and sensory axonal neuropathy, Miller-Fisher syndrome, acute pan-dysautonomia, extensive dysfunction of the autonomic nervous system. How do you diagnose multiple sclerosis? Clinically, there is a score for it. Lumbar puncture, high proteins, high white blood cells, usually the mononuclear white blood cells like the macrophages, like the monocytes, like the lymphocytes. IgG is usually high, and sometimes we see oligoclonal bands. We can order some serum tests, optical coherence tomography or OCT, and evoke responses, and then you MRI the brain and the spinal cord, at least the cervical spinal cord, to find all kinds of lesions, including hyperintense lesions, Dawson fingers, punctate lesions, enhanced lesions, and ovoid lesions, and more. If you want me to create a special video on the MRI lesions of multiple sclerosis, please let me know in the comments. How do we diagnose Guillain-Barré Syndrome? Albuminocytologic dissociation in the CSF. What does that mean? Albumin is high, but the cells are not. What kind of cells? White blood cells. Then we do electromyogram and nerve conduction studies because this is a peripheral nervous system disease. We need to see symptoms in 2 or more nerves. And of course, the conduction velocity will be diminished. Some variants of Guillain-Barré syndrome have IgG antibodies against gangliosides. Remember that gangliosides are parts of the nerve. You can learn more about gangliosides in my videos on sphingolipidosis or lysosomal storage diseases, which can be found in my biochemistry playlist. If everything fails, you can biopsy the nerve, and of course, this is autoimmune, so you'll find monocytes and T-cell infiltrating the nerves and causing segmental demyelination. How do we treat multiple sclerosis? Try to avoid exposure to heat. Physical therapy. Acute treatment includes IV methylprednisone. Plasma exchange can help to remove those nasty antibodies that are attacking the oligodendrocytes and replace the plasma with new plasma that does not have the nasty autoantibodies. For chronic management of MS, we have interferon beta-1a, we have galtiramir, we have fingolimod, which is a modulator of the sphingosine, and we have a bunch of monoclonal antibodies that happen to be humanized against the immune system, such as natalizumab, alemtuzumab, and ocrelizumab. But how do we manage Guillain-Barré syndrome? Take care of the lungs, because respiratory insufficiency is common and deadly. Give intravenous immunoglobulin or plasma exchange, mechanical ventilation if needed. Can we give glucocorticoids in multiple sclerosis? The answer is yes. Should we give glucocorticoids in Guillain-Barré syndrome? The answer is no. Can we give glucocorticoids to manage myasthenia gravis, which is the topic of the next video? The answer is yes. Here is multiple sclerosis in 1 minute. The patient is usually 20 to 40 years old, mostly females, northern, with vitamin D deficiency and decreased sunlight exposure, or a smoker. Symptoms include internuclear ophthalmoplegia, muscle weakness, sensory problems, whether hyposthesia or hyperesthesia, Otto's phenomena, positive Lermite sign, nystagmus, internuclear ophthalmoplegia. By the way, if you want to learn more about internuclear ophthalmoplegia and the medial longitudinal fasciculus, please refer to my neuroanatomy playlist. There is a video on this topic, which is very high yield. Upper motor neuron lesion with positive Babinski sign, hypertonia, hyperreflexia, and spasticity. Tingling and numbness are sensory issues. Diagnose MS clinically, lumbar puncture, look for oligoclonal bands in the cerebrospinal fluid, and do MRI of the brain and of the spinal cord. Treatment with intravenous methylprednisone, plasma exchange or plasmapheresis, interferon beta-1a, galtiramir, and fingolimod, and many monoclonal antibodies. Guillain-Barré syndrome in 1 minute. The patient had a viral infection or a bacterial infection with Campylobacter jejuni or inoculation, and then 1 to 4 weeks later starts to suffer some neurological symptoms, including difficulty getting up from a chair, difficulty climbing stairs, dysphagia, physical exam, motor weakness in more than one limb with absent deep tendon reflexes, symmetrical weakness, facial weakness, eye muscle weakness, ascending paralysis, respiratory insufficiency, paresthesias, and autonomic symptoms, but for the most part it's a motor disease. Diagnosis with lumbar puncture, look for albuminocytological dissociation. The albumin is high, but the cells are low or absent. Electromyography or nerve conduction studies, I'll see 2 or more motor nerves suffering, such as reduction of conduction velocity. By the way, if you want to learn more about electromyography, check out my physiology playlist. I have a video on that. How can we manage Guillain-Barré syndrome? Intravenous immunoglobulin, plasma exchange, and plasmapheresis. My favorite part of the lecture. Quiz time. In Guillain-Barré syndrome, the deep tendon reflexes are, is it A, B, or C? In myasthenia gravis, the deep tendon reflexes are, is it A, B, or C? Third question, in Guillain-Barré, the muscle weakness is mostly, is it proximal or distal? And in myasthenia gravis, the muscle weakness is mostly, is it proximal or distal? Let me know your answers in the comments. You will find the answer key in the video titled Lambert-Eaton myasthenic syndrome, or LEMS, which could be a paraneoplastic syndrome associated with small cell lung cancer. Do you want to learn about strokes and transient ischemic attacks? Do you want to learn about angina and myocardial infarction? Would you like to learn about cardiac arrhythmias, ARDS, acute limb ischemia, drowning, and all of the toxidromes that you can imagine? Download my emergency medicine high yields course at medicosisperfectionalis.com. It comes with videos, notes, and cases. To learn about neurosurgery, cardiothoracic surgery, trauma surgery, vascular surgery, general surgery, preoperative care, postoperative care, and more, download my surgery high yields course on my website. To learn about the anesthetics, general and local, the stimulants, the sedatives, the hypnotics, the anti-epileptics, the antidepressants, the antipsychotics, and the anti-Parkinsonian medications, download my neuropharmacology course at medicosisperfectionalis.com. If you found these videos to be helpful, please consider supporting my channel by buying me a coffee. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.